And we are live, you can start.
Good evening all. I welcome you to the day 5 of Diabetes Awareness Week under the aegis of the Endocrine Society of India and the Southeast Asian Federation of Endocrine Society. I'm Dr. Anshita Agarwal, working as consultant endocrinologist at New Delhi, India. And on behalf of ESI and SAFES, I extend a warm welcome to today's distinguished and erudite gathering of eminent endocrinologists across the length and breadth of Southeast Asia. I also welcome our audience who have joined us live via various social media platforms. The theme for today, which says it all, is A Stitch in Time Saves Lives. As we all know, diabetes is not just an isolated disease, but in fact a multi-system disorder that unfortunately hardly leaves any organ untouched. Two very important and dreaded complications of diabetes pertain to cardiovascular or cardiac disease and diabetic nephropathy or diabetic kidney disease. It is really heartening and encouraging to know, however, that early diagnosis and treatment of these complications can help us in prevention and management to a great extent. To shed further light on this issue, we have two very interesting panel discussions lined up today. The first panel discussion is on how to keep your kidneys safe, and the second one is on heart-to-heart in diabetes mellitus. So, without much further ado, I'd like to take the opportunity to introduce the faculty for the first panel. Our panel consists of one moderator and three panelists who are all distinguished in their fields of endocrinology in their respective countries. So, I welcome you all. To begin with, I'd like to invite Dr. Suresh Kumar, who's the moderator for the first session. Sir is the Assistant Professor of Endocrinology at the Bolam University of Medical and Health Sciences, Quetta. He's also working as consultant physician and endocrinologist at the Sandimang Provincial Hospital at Quetta, and he's an executive member of Pakistan Endocrine Society. We welcome you, sir.
Thank you.
Now further, yes, sir. Now further, I'd like to invite the three eminent panelists of today's discussion. First of all, I invite Dr. Zareen Kiran, who's working as an assistant professor of endocrinology in the National Institute of Diabetes and Endocrinology at the DUHS University. And she's also working as a consultant of endocrinology at the Aga Khan University. Ma'am has a keen interest in teaching and research, and she is intimately involved in the MBBS curriculum and teaching. Apart from that, she is registered as a supervisor in fellowship training in endocrinology by the College of Physicians and Surgeons of Pakistan. Her key areas of interest include female endocrinology, which varies from amenorrhea to thyroid disorders in pregnancy. I extend a very warm welcome to you, ma'am.
Anshita, for a nice introduction.
Next, we have with us Dr. Sachit Abhayaratna, who is a board certified specialist in endocrinology and is working as a senior lecturer in pharmacology at the Faculty of Medical Sciences at the University of Colombo. Sir has been the secretary of the Sri Lanka College of Endocrinologists from the year 2017 till 18 and is currently serving as a co-editor of the Sri Lanka Journal of Diabetes, Endocrinology and Metabolism. He's a council member of the Sri Lanka College of Endocrinologists, and he's also a fellow of the American College of Endocrinology. Sir also has a keen interest in teaching, and he is involved in postgraduate training examination in endocrinology and pharmacology, and is a member in the board of study in endocrinology and pharmacology at the University of Colombo. We extend a warm welcome to you, sir.
Thank you, Anshita, for the nice introduction.
So now I would like Dr. Suresh Kumar, who is the moderator for the session, to kindly kickstart the interesting session for today.
Good evening, everyone. Thank you, Dr. Anshita, for the nice introduction. You have been constantly in touch with all of us regarding intimating the format of the program. I hope it will help a great deal to carry on this program successfully. As we know that kidneys play a very important and vital role in the homeostasis of body. They filter blood, they help in getting rid of the waste material from the body, And as we know that today's discussion is keep your kidneys safe. Diabetes, as we know, is growing leaps and bounds day by day. Likewise, the complications of the diabetes are on the rise too. So my question will be in the context of complications of the diabetes. So the first question that I'm going to put is before Dr. Zareen Kiran. Dr. Zareen, how common is DKD in diabetic patient? To elaborate it further, I would say how common is DKD in type 1 and type 2 diabetic patient?
Thank you, Suresh, Dr. Suresh, for addressing the question. This is actually a burning question. I think many of us may not really be aware with the single figure as to what is the real, prevalence of diabetic kidney disease among diabetics in our region, especially the South Asian region. Because, there is a wide variation among as to how the exact data has been collected. Number one. Number two is that many of the diabetic patients who are, harboring this kidney problem, they actually die before coming into, healthcare attention, unfortunately. So, and even if they do come to healthcare attention at various stages of kidney disease, say, for example, stage 3, stage 4, that is the advanced type of kidney disease when the end stage has come and they are requiring renal replacement therapy. Unfortunately, at that time, what remains is that to manage that problem and manage the renal replacement therapy itself, rather than identifying the cause. So they often do never undergo biopsy of the kidney to reveal the cause. And we label them that this patient, so as this patient has diabetes for so and so duration, so this is the cause of the kidney disease. So, but if for this purpose and for us to know the exact number, I searched through the literature, and unfortunately, when I got through it, I was alarmed to see that the end-stage kidney disease itself has 80% prevalence secondary to diabetes itself. That means almost 80% of the cause of the end-stage kidney disease. If you go into any of the kidney centers or dialysis center, you'll come to know that the 80% of the cause is diabetes. But if you talk individually, as you asked, that we should know about type 1 and type 2 as well. So again, the data is quite variable. One of the relevant research relevant to our population, South Asian region, I found that type 1 had 14% prevalence, whereas type 2 definitely has double, almost 25 to 30%. And globally, it is again 25 to 30% overall in diabetes that they suffer from kidney disease. So unfortunately, it's a kind of a situation where we are stuck with diabetes, not only diabetes, control of diabetes, the glycemic targets, the various hemoglobin A1C, the time in range, and so on. We are also stuck with the targets of our complications. How to handle that? What is the number? How to prevent that? So so type 1s usually have a lower prevalence, a lower common being amongst them as compared to type 2. But again, remember, we are also facing another type of diabetes now in our area. That is young onset type 2 diabetes. The young onset, the youth in our population, the teenagers, because of our lifestyle, because of our sedentary behavior, because of our eating habit, whatever you say. The young onset type 2 diabetic patients, since they are having longer duration of diabetes with them, they are coming up with the earlier presentation of kidney problems. So again, we have to search and do work on the data on their prevalence as a separate entity. So type 1 rough around 14-15%, but type 2 25%. And again, the young onset, we have to work on that. We don't know. So this is how common it is. I hope I answered.
Dr. Zareen, do we have any local data? Do we have any local data of diabetic kidney disease?
So apparently in Asian region, we don't really have that local data. Even the kidney center, the core kidney related healthcare facilities, what they report is nearly 80 to 90% of their end-stage renal problems being linked with diabetes. So overall, in diabetics, how much kidney problems do we get? We don't have that. But the people who land in kidney centers, who land in dialysis centers, they are the one where you can see that amongst the dialysis patients, the patients requiring renal transplants, the main cause remains diabetes. Even if sometimes there is no diabetes, but the diabetes type of pathophysiology is going on in the kidney related to the obesity. And the obesity related glomerulosclerosis is another term now coming up in diabetic in chronic kidney disease area, where you finding the similar problem which is related to obesity. So obesity is linked with diabetes again. So I mean, what will you say that majority of the kidney patients coming up to for dialysis, for renal replacements, transplants, they are having the core cause behind all that issue is diabetes, uncontrolled sugars.
Okay, thank you very much, Dr. Zareen. Very nicely elaborated. Do we have
sir, could you
Dr.
please excuse me for a second? Yes, sir. Pardon me, sir. I've missed introducing a fourth eminent panelist somehow. Please pardon me for that. So I'd also like to welcome Dr. Ahmed Zia Mukhlis to our panel. Sir is a medical specialist and endocrinologist, and he's the vice president of the Afghan Endocrine Society. He's also the chief of internal medicine department of the Central Polyclinic at Kabul. Sir, we welcome you warmly to our panel. And now I request Dr. Suresh to
Good evening. Hello, everyone.
Good evening, sir.
So sweet. Thank you very much for so sweet introduction. Thank you.
Dr. Ahmed, I've got a question for you. Are you ready for the question?
Yes. Yes. Suresh?
Okay, yes. Dr.
Do you hear me?
My question, yes, I can hear you. My question to you is, when does diabetic kidney disease occur in type 1 and type 2 diabetic patients?
Hello? Do you hear me, Suresh?
Yes, I can hear you. Can you hear me?
Yes.
Okay.
Diabetic kidney disease, also termed chronic kidney disease, due to diabetes or diabetes nephropathy, is defined in the both type 1 and type 2 diabetes as presence of persisting severely elevated albuminuria, more of 300 mg per 24 hours, or more than 200 mg per minute on albumin, and creatinine ratio more than 300 mg per gram, confirmed at least to two separated samples with concurrent presence of diabetes retinopathy and absence of any sign of other form of kidney disease. This is called Hello?
Yeah, we can hear you. Please carry on.
Yes, sir, you're audible.
In this situation, we call that this is a diabetic kidney disease in both form of diabetes.
Okay. My question to you is, when does diabetic kidney disease occur in type 1 and type 2 diabetic patients?
Hello? As I mentioned, Suresh,
Yeah. I can hear you.
diabetic kidney disease, also termed as CKD or diabetic nephropathy, is defined in the both type of diabetes as presence of persisting severely elevated albuminuria of more than 3 mg per 24 hours, or more than 200 mg per minute, and albumin to creatinine ratio more than 300 mg per gram, confirmed at least in two separate samples of urine when concurrent presence of diabetic retinopathy and absence of sign and symptom of other form of renal disease. So this condition we call to have common in the diabetes patient.
Okay, so this is the definition of diabetic kidney disease. Okay, I got it. So moving to the next question. My next question is from Dr. Sachit. Dr. Sachit, what are the signs and symptoms of diabetic kidney disease? How does patient come to know?
Yes, Dr. Suresh. Yeah, I hope you all can hear me.
Yes, sir,
Yeah,
we can hear you.
yeah. So your question was, what are the signs and symptoms of diabetic kidney disease? So as we know, I think it's a common thing in our whole region that diabetic patients, even when they are diagnosed with diabetes, most of them don't know that they have diabetes. They don't have symptoms. And it is exactly the same with diabetic kidney disease. Now, in our clinics, we know that if you ask patients about their cholesterol, they know about it. If you ask about their blood sugars, they know about it. But if you ask them whether you have diabetic kidney disease or not, whether you are aware, most of them, about half of them, will not know. The reason for this is that just like diabetes, diabetic kidney disease also is asymptomatic most of the time. Generally, when there is diabetic kidney disease, we grade it according to the severity. So we give about 5 grades. We take a measurement called estimated GFR, that is how we calculate the percentage of kidney function. So up to about 40% of your kidney function is working. Up to that level, you may not get any symptoms just because of diabetic kidney disease. So most patients will not know unless we screen them specifically with certain tests to diagnose it. But when the kidney function falls below that level, roughly about less than 40% of kidney functioning, then the patients might develop some of the symptoms of diabetic kidney disease. So the common ones are, mostly we know that our kidneys are the main organs which excrete the water. So when there is kidney disease, severe kidney disease, that function will be impaired. So kidney will not be able to handle water efficiently. So there will be water retention. So most of the time, patients will develop swelling of their ankles. Then it can develop into a severe stage up the level of hands, and even under their eyes also we can see some swelling. And then sometimes with the kidney impairment, we get electrolyte imbalances. So some of the most important ones we are talking about is our sodium level and the potassium level in the blood. So when the potassium level generally tend to go up when they have kidney disease. So when with high potassium, they might get a little bit of muscle pains, muscle aches, those things are also common. And then kidneys, as you know, are the ones which handle the most of the toxins which will be excreted out of the kidneys. So once they accumulate, patients will develop some symptoms, common symptoms like nausea, vomiting, and very severe stages, they can lead into certain encephalopathy stage where they can go into coma situation as well. And the other common things are they can commonly get low blood counts, which we call as anemia, because kidneys are important in producing a hormone which promotes blood cell production from the bone marrow called erythropoietin. So when the kidneys are defected, these hormones will not be made. So therefore, patients can commonly go into anemia, and anemia can manifest as fatigue, difficulty in concentration, that kind of symptoms can happen. So these are the common ones. Apart from that, the doctors might detect high blood pressure, which is a common association with kidney disease. So with that would be another thing. And then if they examine your heart, they might find that certain abnormal heart sounds. So those are some of the other ways patients can present. And we also know that kidney disease and the diabetic eye disease, they also have a link. So sometimes the eye doctor may find that there are some eye problems and they might advise them to go for a kidney screening test. So these are the ways how the diabetic kidney disease could present. But the most important thing we have to remember is most of the time it is asymptomatic. So we have to do active screening to find out these patients.
Dr. Suresh, are you there? I think sir is having some network issues. Yes, sir. Dr. Suresh, can you hear us? I think having some network issues. Maybe in the meantime, we can carry forward the discussion. So,
yeah, I think there's another question. I think I also would like to add a little bit about the when would these patients type 1 and type 2 will develop diabetic kidney disease. So generally for type 2, it's after about 10 years or so, we generally see that. But having said that, they can even present earlier than that, because we know by the time we diagnose diabetes, they should have diabetes for some period as well, because diabetes is also an asymptomatic disease in most patients. So they can present early, but it also again depends on how well their control has been. So if their control has been poor, they might present early. But otherwise, in most patients, we see diabetic kidney disease and other complications like that after about 10 years or so. But in type 1 diabetes, again, it depends on their control, but generally, we would like to screen them for these complications after about 5 years from the diagnosis, because we can precisely diagnose when they have got the disease. So from that time, after about 5 years or so, we'll need to do regular screening so that we'll be able to diagnose diabetes in this group.
I think Dr. Suresh is back with us now. Sir, are you here? I think he's having some problem. So in the meantime, till the time Sir joins us, I think we can carry forward the discussion with Dr. Zareen Kirma. If I could ask a question from my side until the time Sir joins. We were just talking about how Dr. Abhay Ratna just mentioned that how in the initial stages of diabetic nephropathy, there might not be any symptoms. The patient might be asymptomatic or might have very negligible symptoms. So how can we detect this diabetic kidney disease early on in the pre-symptomatic stage, ma'am?
So, you know, the most effective strategy to reduce the impact of diabetic kidney disease is actually to prevent type 2 diabetes, right? And after that, even if those who have been affected by diabetes, is to reduce the complications, avoid developing complications, so as to, you know, prolong the life of diabetic patient who can, you know, actually have the same number of life years to live as a non-diabetic without developing complications. And among those complications, we have microvascular and macrovascular complications. Like microvascular means the vessels which are very small and are involved in the eye, in the retina of the eye, in the kidneys, and among the nerves. They are very small vessels, right? And as high blood sugars affect all these vessels, so these micro vessels, these small vessels, can affect these target organs, that is the nerves, the kidneys, and the eyes. And without, the eyes are so important, the kidneys are so important, so screen them, timely screen them, so that you can detect them in the early stage if they are being affected or not by the presence of high blood sugars or diabetes itself. And if they are being affected, the screening tool can help you detect the problem so that you can prevent them getting complicated towards failure. So for example, if I talk about eyes, although we don't have the topic of eyes today, but if we talk about eyes, if we prevent or if we screen them from the very early stage, we can prevent blindness in a diabetic patient. Just imagine a person who is not able to see, who is not able to visualize what is around him or her. What a great benefit would that patient get after having to know that something is happening in my eye, and he or she timely gets the treatment and prevents from developing blindness. Same goes with kidneys. Kidneys are an important organ in the body, and they help filter the unwanted poisons and toxins from the blood, get them away from the body. So they have to function well. They are vital organs, and without them you are dependent on a machine, for example a dialysis machine, or you want a replacement, you want a transplant, you want a new kidney, and it's not very easy in our South Asian regions. We are either underdeveloped or developing stage people. So screening is the best tool to, pick the diabetic kidney disease in the early stage. And how you can do that? Often patients come to you, and as per standard of care, with whatever guideline in the world you follow, you ask them to do certain tests, and those tests can involve your kidney test. I ask my patients, these are the tests for your kidney. Patient says, why do I need to test? I have no problem with the kidney. I have no symptoms. I don't have any pain. They often point towards their back, their lumbar region. There is nothing around here. Why? Why do you want? So you have to teach them. You have to tell them that this is something silent. You may not feel the symptoms. This is the asymptomatic stage. And if we pick up the silent stage at this time, through this test which I give you, it will save you. It will be cost effective for you. So it is a very, the tests are not very hi-fi tests. Of course, for a very poor person, any test, any treatment is definitely costly, but these are not very big tests to give an impression for a layman that, oh, such kind of test we have to do. But this is a simple urine test and a simple blood test. In the urine, you have to check for microalbuminuria, and in the blood, you have to check for the kidney function. And that kidney function is actually a glomerular filtration rate or a creatinine clearance with whatever formula or a guideline you follow. But this is a bit scientific to know, but it actually tells you your renal function, your kidney function at this stage. And in the diabetic patient, in the very early stage, it can be affected. It can be picked up in the early stage and then treated likewise. So again, as I had mentioned in my previous response to the question as well, that there are two major types of diabetes we are dealing with, type 1 and type 2. In patients who are type 2, if you're considering that the patient who has a type 2 diabetes, you have to screen them right at the time of diagnosis. Patient comes to you for the first time, tells you that this is the test, now I'm diabetic. You have to start the treatment. You have to control the sugars, of course, but along with that, you have to do many other things. And in that thing, screening is very important, and screening of the kidney is very important. Screening of the eyes is very important. And at that time, you have to order these tests, the urine for microalbumin and the kidney function through the blood test. You have to write them down. And whereas in case of a type 1 patient, usually type 1 patients, they develop chronic complications, or you can say microvascular complications, the small blood vessel related complications, after around 5 years. This is what the research or scientific data in the world has shown us. So screen them not at the time of diagnosis if they are asymptomatic and if they don't show the signs of any kidney dysfunction or eye problem or anything else. But if they are coming to you after 5 years, they are following you, or a duration of 5 years has elapsed after their diagnosis, then now it is the time that you have to screen them, you have to order them. So initial stage, through a urine test, through a blood test which tells you the kidney function, is very, very simple, very, very commonly done, and can pick up the patient in the early stage when the patient is not even symptomatic. As my colleague here, Dr. Sorry, I'm unable to recall his
Dr.
name,
Sachit,
but he just
Sachit,
mentioned,
yeah.
sorry, Dr. Sachit, yes, he just mentioned that patient can present with nausea, patient can present with, swelling around the body and so on. But sometimes patients, they don't feel such symptoms. Even in the initial stages, I am not even talking about a very initial stage, we call in our scientific term as incipient nephropathy, when even the renal function is actually good, the kidney function is actually good. But even in the stage 1, stage 2, where the kidney function has started to decline, patient remains asymptomatic sometimes, and they often it often comes as a surprise when they come with a blood test back to you as a follow-up, and they tell you that something is wrong in the test, doctor. The range is out. The creatinine level, for example, is out of the range, and the microalbumin level is also out of the range. Is it something to worry? I don't have any symptoms. There is nothing wrong. But at that time, that is the time that you have to see that is this patient now in the early stages of diabetic kidney disease or not. Of course, you have to do, there are other protocols and other standard of care methods how to deal with that. But that is the sign, that is the alarming point when you have to tell the patient, see, I screened you, I picked you at the early stage, now we will be able to handle it. So I hope that it makes clear that even someone who is asymptomatic, no symptoms, can be screened at the early stage through these simple tests, type 2, right at the time of diagnosis, and then after every year, annual basis. You have to check these tests on annual basis. And for type 1, if the 5 years duration has elapsed, then they should undergo this screening test for their kidneys every year. And this can save them from having a advanced stage kidney disease, save them from undergoing dialysis and its havoc day in and day night, and all that big problem, economic problem, financial, social, and psychological burden of renal transplant therapy. So I hope I answered that question, and I'm on the track.
Yes, ma'am, you explained really beautifully. Now, carrying forward the discussion, ma'am just mentioned about how we can pick up these diseases in the pre-symptomatic stage and how frequently we should monitor for these. So I would like to ask Dr. Ahmed Zia Mukhlis, sir, in your practice, how frequently do you get this monitoring done? Just to get a perspective from you also, sir.
As Karen mentioned that every patient, when he came to clinic, that should be evaluated not just for diabetes, but also for the kidney function test, and also for referring to an idea about the eyes and some what else that affect the on kidneys. And this procedure we also done in our private clinic in hospitals, that every patient should be evaluated in every dimension that affect the process of diabetic kidney disease.
Okay, sir. Okay, sir. Thanks a lot for your perspective. Now, as you were talking about microalbuminuria, being one of the red flags for diabetic nephropathy being seen. So I would like to ask Dr. Sachit Avaratna, sir, is microalbuminuria synonymous for diabetic kidney disease, or could there be other reasons for microalbuminuria as well?
Yes, we know that microalbuminuria is a main early sign of diabetic kidney disease, but there are other diseases and other instances where they can have microalbumin in urine. So a few things would be, now if they do very heavy exercises just before they do the test, then there could be a false positive microalbumin level happening. And then there are other instances if the patient is ill, if is under severe stress, or let's say after surgery or anesthesia and that kind of thing, that is not a good time to check for microalbumin. And most of the time, though we tend to screen these type 2 diabetic patients because we don't know how long they had diabetes beforehand, we tend to screen them. If they are coming with uncontrolled blood sugar, with very high blood sugars, that is again not a good time to test for microalbumin, because we know that when blood sugars are high, you can get false positive microalbumin, which would settle after you treat their diabetes for a reasonable period of time. So it's better in those patients, first you treat diabetes, get them under control, and then look for whether microalbumin levels are positive. And the other common things are, now we know that diabetic patients, they are more prone to get infections, and urinary tract infections are a very common one. And if you have a urinary tract infection, invariably you'll have proteins and red blood cells in your urine. So it's again not a good time to check. First, if you detect urinary tract infection, you have to treat it, and then you can check for microalbumin at a later time. And then in females, sometimes after menstruation, there could be false positive readings that again you have to be mindful. And sometimes if they take excessive amount of protein, sometimes these bodybuilders and these people, they use excess amount of protein, that also sometimes can cause a little bit of false positive test. And then obesity, extreme obesity also sometimes shown to increase the levels of microalbumin passing urine. So we have to be mindful about that. With that, knowing about that, we'll have to interpret these tests.
Okay, so I think that was really informative. So now we know that microalbuminuria may not always point towards diabetic nephropathy. There are other certain conditions that must be ruled out. So that is why we emphasize on repeating it at least twice or thrice before we conclude that the patient has diabetic nephropathy. Now, one question that comes to my mind, asking Dr. Zareen Kiran ma'am, nothing prevents a diabetic patient from getting a non-diabetic kidney disease, right? Because there are other causes of renal failure as well, and they might have some different treatment regimens. So how can we differentiate in a diabetic patient whether it's having diabetic kidney disease or non-diabetic kidney disease?
These diabetic patients, they can have other problems, not only diabetes, like they can have hypertension. They can have bladder dysfunction, which can actually lead to, kidney dysfunction for neuropathic bladders and, incontinence and vesico-urinary reflux and so on. And then some may have recurrent UTI due to underlying renal stones for one reason or the other. And then there are other vascular angiopathies, which can lead to, autoimmune causes, so many other causes which a diabetic patient can actually have. If you take a good history, good symptom digging, then you may be able to pick these things from a diabetic patient, and a good clinician would do that. And a patient who is being treated due to these non-diabetic conditions may be showing you the medications, the prescriptions, where you may find medications which can point towards, these other causes. Like, for example, if there is an autoimmune disease going on, and a patient may be suffering from urinary tract infection, may be kept on some prolonged type of antibiotics, then this can give you a hint that maybe this is not related to diabetes, and then you dig in. But then again, we know as expert endocrinologists and as diabetologists that how a diabetic kidney disease develops and presents, right? We know the background of the pathophysiology, the pathogenesis. The longer the duration of diabetes, usually no signs as such. The presence of microalbuminuria, along with the presence of retinopathy, and a progressive kind of a decline in the kidney function, the estimated GFR that I mentioned earlier, or the creatinine clearance. This gives you, and of course, when you look at the urine detail report, there is no other gross abnormality other than, either proteinuria, which is also very less, or presence of actually microalbuminuria. This can give you a hint that, okay, this is related to diabetes, making sure there are no other pointers of, non-diabetic illness or medical problems in a patient with diabetes. But having said that, there are still other conditions. There are still variations in this presentation. Not always that the patient having a diabetic nephropathy or kidney disease should have a retinopathy. They can present with a kidney problem in the first stage at diagnosis. We often, practice, and in our training, in our fellowship program, we have seen that the first presentation in the emergency of a patient landing in emergency with a kidney problem has actually an undiagnosed underlying diabetes, a very high hemoglobin A1C. Oh, this is the first time. So, and the eyes are normal, this can happen. And the data is now coming up with such kind of presentations that they are not harboring that typical retinopathy before having developed this nephropathy for one reason or the other. And this is kind of a same throughout the world, actually. This is not something specific to us. Then coming on to the investigation, when you order a test, this is how you take a history. You get a hint from taking a proper detailed history, medical evaluation of the patient, medical prescription, chronic illness situation. But then you order certain tests to make sure that this is not related to diabetes or this is related to diabetes. Then when you see active sediment, active urinary sediment that is present of red blood cells, cast, or the crystals, that can tell you, okay, this is something else. This is not only glomerulus, or this is not specific to the albuminuria. This may be related to the stones, or this may be related to something like microangiopathies related to autoimmune diseases. And then a rapid decline, a rapidly declining kidney function. That should also give you a hint, because diabetes is usually a chronic, slowly progressive illness. So a rapid decline, a sudden rise in the creatinine level, for example, or a sudden decline in the estimated GFR kidney function, that should give you a hint that this is not related to diabetes. Diabetes is well controlled. Why is this happening? And again, a sudden development of gross nephrotic syndrome, gross proteinuria should give you a hint of this sort. Then in that case, you should think about alternative causes and think about non-diabetic kidney disease related conditions. And often you have to, refer such patients to nephrologist for biopsy and to see if there is something being missed. And in that, if for example, biopsy tells you that this is a typical Kimmel-Steele-Wilson lesion, or typical those glomeruli that we used to study in our pathology, okay, then that can give you, that can save you and tell, okay, this is related to diabetes. But sometimes there can be pictures which are not typical of diabetes, and that can save you, and that can tell you that this is something a nephrologist has to deal on its own. Another thing which I want to add here, I told you a bit variation about how the type 2 type of diabetes can present with a kidney problem, having a sudden development of kidney disease without having without having an underlying retinopathy, for example. Same goes with the type 1 diabetes. Type 1 diabetic patients hardly present to you with a kidney problem at the first instance. They may be harboring a retinal problem already, eye problem. So screen them for retinopathy. Usually they harbor a retinopathy before developing a kidney problem. So, and then the retinopathy can be only moderately severe, not very severe, in the mild or moderate stage, like non-proliferative or pre-proliferative stage. So again, that can give you a hint and tell you that this is a type 1 diabetic patient who is developing kidney problems secondary to diabetes only, rather than a non-diabetic condition. So when you come to clinical, practice, actually, these things become very tricky to address. But we should know the main fact, the cornerstone fact, the duration of diabetes, the slow decline, presence of retinopathy in the most patients, in the prescription of the medications, and the urine detail report telling you that nothing else is wrong except microalbumin. That can give you a differential point that, okay, this is non-diabetic or diabetic.
Okay, so we are glad to have Suresh sir back with us. Sir, can you hear us?
Yeah, I can hear you.
Yeah.
Sorry, my internet connection is a bit unstable.
Okay.
I'm being disconnected time and again. Okay, thank you very much, Dr. Zareen Kiran. I'm going to put next question to Dr. Zia Ahmed. Sir, is there some link of smoking and diet with diabetic kidney disease? Are there some diets, okay, that patients should avoid from taking so that their kidneys may be preserved?
The renal
Am I audible?
lesion most strongly associated with. Do you hear me?
Yes,
sir,
I can hear you.
The renal. Hello.
Yes, sir, you're audible.
The renal lesion most strongly associated with smoking is nephrosclerosis, and significant positive association with have also been reported for glomerulonephrosclerosis. Multiple different and positive interrelated physiological mechanisms may account for these lesions. Chronic smoking could lead to microvascular atherosclerotic disease, which can potentially initiate nephrosclerosis and acceleration of progression of pre-existing diabetic kidneys. Microvascular disease could lead to hypertension, which could be further accelerate diabetic kidney disease progression. More than 400 chemicals are found in cigarette smoker, and it is unclear which of many of these chemicals materials responsible for smoking's deleterious effect on the kidneys. Hello?
Yes, sir. Dr. Suresh, are you there? Okay, I think we have sir again. So coming to Dr. Dr. Suresh, are you there?
Yeah, I'm here.
Yes, sorry. Yes, sir.
I think Dr. Zia is done. I could
Yes,
not hear
sir.
him. Okay.
Yeah.
Sir, Sachit, I have a question for you, sir. Sir, is there some impact of diabetic kidney disease on cardiovascular system in terms of morbidity and mortality?
Yes. So we know that diabetes itself is a significant risk factor for cardiovascular disease because patients who have diabetes are twice more likely to die from a cardiovascular cause than the patients who don't have diabetes. And most of our patients we know ultimately die because of cardiovascular complications of diabetes. Now, having diabetic kidney disease make them more prone to have cardiovascular problems because it has been identified as a significant risk factor. Having diabetic kidney disease is a significant risk factor that will lead towards cardiovascular disease. Now, in fact, if you take if you categorize the kidney function, and if you take the middle category where your kidney function is somewhere between 60% to 30%, in that category, actually, they are more likely to die from a cardiovascular cause than they are going to die from progression of their kidney disease to the end-stage renal failure. So that tells you how significant and how prevalent the cardiovascular disease is among these patients. Another thing is, just like the other risk factors like high blood pressure, cholesterol, the microalbuminuria, as well as the function of the kidney, which we measure by the glomerular filtration rate, they are also being identified as separate independent risk factors for developing cardiovascular disease. So whenever our patients have diabetic kidney disease, not only we need to manage that part and prevent the progression of end-stage kidney disease, but we also have to manage their cardiovascular risk. Otherwise, before they develop kidney disease, the end-stage kidney disease, they will die from a cardiovascular disease. So therefore, we'll have to manage that aspect as well.
Okay, sir. Yes, sir. Thanks for beautifully answering that question, sir. I think it's nearly time to end it. So, few quick questions that I think that we can just complete this session. We were just talking about the link between cardiovascular disease and nephropathy. So now coming to a quick answer, ma'am, from you. How can we prevent diabetic kidney disease? You have to say it in 1 or 2 lines.
Yes, I'll try to be brief now because so much has already been discussed. And of course, prevention is better than cure is a big and old proverb that we often hear in our talks and so on. So of course, to reduce the burden of having a developing diabetic kidney disease and its consequences, the dialysis, the financial issues, the cost, prevent type 2 diabetes in the first stage. Do not, change your lifestyle, change your diet, healthy exercise, and so on. Type 2 diabetes development prevention is the key to it. And if those who have developed diabetes of all types, whether type 1, type 2, youth onset, or whatever, then screen the patient early on and treat the kidney disease in the early stages. Control the blood pressure. Stop smoking, control the dyslipidemia, because again, the dyslipidemia also affects the kidneys. Reduce weight, because obesity is going on to develop its own type of kidney disease now. And of course, not last but not the least, to control the blood sugar, control the numbers. And a good, one of the good medications to prevent the kidney disease to stop the kidney disease from going on to end stage is patients are often put on angiotensin converting enzyme inhibitors or ARBs, the drugs. They can prevent early stage kidney disease from developing to the end stage. So this is how you can prevent the morbid complications or the mortality in such patients.
Thank you, ma'am. Dr. Suresh, do we have you with us? I think not. So, sir, Dr. Ahmed Zia Mukhlisa, any parting remark from you? Ma'am talked about treatment of PKD. Anything quickly that you would like to add?
Hello.
Yes, sir.
Sorry, I didn't got it.
Anything, sir, you would like to add? We are almost winding up the panel. Any parting comments from you regarding the treatment of kidney disease or anything from your side, sir?
Diabetic kidney disease is the medical catastrophe with higher prevalence, poor diagnosis, and lack of novel biomarkers for every diagnosis. So, for better treatment and prevention, globally a connection and being with each other is most important in this COVID-19 state.
Okay, sir. Thank you so much, sir, for your comments. So the last question now for this session for Ratna, sir. We talked about the endocrinologist perspective. When should a DKD patient be referred to a nephrologist, according to you?
Yeah, so that depends actually on the accessibility of the nephrologist. So generally, when the kidney functions reaches around about 30%, so we call that EGFR around 30, then that would be a good time to refer to a nephrologist, because we know below that level, they develop a lot of complications like anemia, acidosis building up, calcium problems will come. So it's better they manage under a nephrologist. And the other things are, if you notice that when the patient's GFR level or the kidney functions are rapidly deteriorating, even at an earlier stage, then it's better to refer to a nephrologist. And we also initially discussed how to identify non-diabetic kidney disease. So if you suspect non-diabetic kidney disease, that is another situation. And sometimes in low GFR levels, patients develop significant edema and uncontrollable hypertension. So those patients might need later on dialysis as well. To plan that, it will be good to refer to a nephrologist when these complications develop.
Thank you so much, sir, for that very elaborate and informative answer. And I think with this, we come to the end of panel 1. I extend a warm thank you to our moderator, Dr. Suresh Kumar. Unfortunately, it was marked by a few technical glitches, but I think that is not in our hands sometimes. We're also very thankful to all the 3 eminent panelists. Really, there was a lot of new things that we learned, and also our audience would have learned a lot. And now probably they won't be so scared of diabetic kidney disease, because now we know that it can be prevented and managed very well. Thank you all so very much. Now, I think we can move on to the next panel, that is heart to heart and diabetes. So this is yet another very interesting session that we have lined up for you. I would like to extend a warm welcome to our moderator and our 3 esteemed panelists. Our moderator for this evening, for this session, is Dr. KVS Harikumar. Sir is a consultant endocrinologist at the Magna Clinics and Fernandez Hospital at Hyderabad in India. He has been the recipient of numerous accolades and awards, including the Shakuntala Amritsar and M.N. Sen Oration Award from ICMR New Delhi, the ARC Gold Medal, the J.S. Bajaj Oration Award, Thyroid Rising Star Oration Award, and Young Investigator Award from RSSDI. Sir has had numerous peer-reviewed publications in various journals of repute, and he enjoys being on the editorial board of nearly 8 journals. So we welcome you, sir, as a moderator of our session. Next, I would like to introduce, coming to our panelists, I welcome Dr. Amna Riaz. Welcome, ma'am. Ma'am is the assistant professor and head of endocrinology at the Al Alim Medical College and the Gulab Devi Teaching Hospital at Lahore in Pakistan. Ma'am is also has keen interest in academics and research. So we are glad to have you, ma'am, with us. Next, we have with us Dr. Uniba Saeed. Ma'am is a a clinical research certified professional and a certified professional in medical teaching. She's also the assistant professor of endocrinology in the Services Hospital at Lahore. And she's one of the executive members of Pakistan Endocrine Society and has numerous international publications to her credit. Extend a warm welcome to you, ma'am, as well.
Thank you, Anchita. Thank you.
Welcome, ma'am. Now I'd like to invite Dr. Tara Koirala, who's the third panelist for today evening. Sir has done a fellowship in endocrinology and diabetes, and he's a consultant endocrinologist at the Pokhara Super Speciality Hospital at Nepal. And he's also one of the executive members of the Dean Society. Extend a warm welcome to you, sir.
Thank you. Thank you.
Welcome, sir. So with this, I would request Dr. KVS Harikumar to kindly set the ball rolling for this session.
Thank you, Dr. Anshita. Welcome on behalf of the Endocrine Society of India. I welcome all the panelists for this discussion. Only two housekeeping announcements. Just try and be as patient-friendly terminology as possible, because this is absolutely meant for public. So I will moderate it in such a way that only somebody who is listening in the public should feel the benefit. Keep it at MBBS or maybe minus MBBS level is the good enough. Okay. So before we start, we will not waste much time. We will go to, whenever we look at the cardiovascular issues, that is the #1 killer as far as diabetes patients are concerned. So I will just keep on posing some case scenarios, some patient scenarios, which you will be encountering in day-to-day life and how best to tackle. Okay. So we will start with Dr. Uniba first. 40-year-old gentleman recently detected diabetes. Okay. He's well controlled, maybe with metformin or a gliptin combination, non-obese. One friend advised, why don't you take a ecosprin or a antiplatelet so that you don't get a heart attack, because we are worried that you're going to die because of heart attack. So why are you not taking a ecosprin? Or my doctor has prescribed. So what are your comments?
Thank you, Dr. Kumar. The scenario that you have actually presented is very common. And this is the question that we, almost all of us, we just have it daily from our patients. Now, aspirin is a drug which has a certified role in the secondary prevention. That is, if the patient already has a cardiovascular event in the past, though aspirin has a role. Now, the question comes that if the patient like this one is of the age less than 40 years, has a newly onset of diabetes, and as far as I could understand, is not obese, and there are no other risk factors. So now here the guidelines come in. Although the primary prevention, when we look at it, there are few research papers who they are for it, and there are few who do not. They tell that we have benefit out of it. But then we have to individualize it. Coming to this patient, I'll just give you a little bit of, just background of a knowledge that if the patient is, in this case, first I'll take this case. If the patient is less than 40, or as per guidelines, if the patient is less than 50 with not much of an additional risk factors, patient does not need any aspirin at all. It will not benefit him as far as primary prevention is concerned. However, if there are patients who are like more than 50 years of age, are diabetic patients, and have more than one risk factor, then obviously you can give the aspirin. The risk factors that we say is the patient is obese, patient has a family history of premature cardiovascular diseases and stuff, or it has hypertension. So in that case, we can consider the aspirin as a primary preventive drug, saying that the patient should not be having a greater risk of the bleeding. If you come to another age group that is more than 70, let's say your patient is of more than 70 and he wants to take the aspirin. So now what happens is that we actually look for the risk and benefit ratio. In that age group, we know that the risk is a little more than the benefit, the bleeding risk, especially the gastrointestinal tract bleeding risk. So in that case, it has to be a shared decision of a multidisciplinary team as well. But if a patient comes to you with the age less than 20, you can just say simply no, that it's absolutely contraindicated. And one thing I like to say, whoever is prescribed an aspirin, it should be, at the lowest possible dose, maybe starting from the 75 milligram. I hope that answers your question.
Yeah, perfect. Actually, the key take home message is, one, most of the times problem what happens is the moment you're detected with diabetes, there are other than anti-diabetic 3-4 drugs which just come into the prescription. So we are just trying to educate people. Secondary prevention, no doubt. Secondary, I mean, once suffered a vascular event, if you are preventing a second vascular event is known as a secondary prevention. There is no doubt, no controversy, it is absolutely required. If you have not had any vascular event and you're trying to prevent a vascular event, as madam has rightly said, less than 50, it is only case-based or maybe with severe risk factors, significant risk factors. Beyond 50, you can consider, but less than 50, generally don't consider. Any other panelists would like to contribute on this? Dr. Amna, Dr. Tara, any other?
Thank you. I think it was perfectly explained, and really the take-home message should be that one should not be very eager in taking the aspirin, because at younger age the benefit is less than the risk are more than the benefit, and the bleeding risk is much more higher, and that can put the patient in much trouble in hopes of taking aspirin and preventing heart disease. So damage could be more than the benefit.
Okay, hello everyone. What I like to add here is that even aspirin, if you consider the diabetic patients itself, the aspirin may not work as compared to the non-diabetic patients. You know that studies have shown that the diabetic patient may have the different platelet activities as compared to the non-diabetic, and the problem with the prothrombotic state of the diabetic patients may not be the platelet function itself, but the coagulation factors. You know, they have the quantitative as well as the qualitative changes in the coagulation factors. So giving aspirin alone may not work. And sometimes, yes, there have been studies which are, not so much robust studies have come yet. Only which we can rely on is the ASCENT study, which have shown some sorts of, help to us. But what I can say is, if really patients, if you think will be benefited from aspirin, what you can do is maybe the dose of the aspirin, a low dose, as already Dr. has said, and sometimes they have been studies giving twice a daily aspirin. That may also be helpful. But still, I think we should need more data on this to be, to be sure and to address this issue.
Thank you, Dr. Tara. As I said, it's like the aspirin resistance and all those issues. Yeah. We shall keep it for CMEs. We will keep this for public education. So the issues, absolutely correct. But only another message rightly put from Dr. Tara is, if despite taking aspirin, you are getting a repeated vascular events, please go back to your doctor and ask, is there something that my aspirin is not working? Or am I resistant to aspirin that I should go something else? Yes. So that is a very well point which has brought out that it is not the first stop and the only stop solution. You can take it and convey the message to your treating doctor accordingly. Okay.
And don't take it yourself. Let the doctor prescribe you.
Absolutely. Absolutely. And we'll move to a next case scenario. Same patient, let us presume 40-year-old man, well-controlled diabetic. Now we discussed about cardiovascular prevention with aspirin. Now another friend advised, we discussed about how best to address the nephropathy issues when kidney is also equally kills any number of diabetic patients. So somebody said, why don't you take a ramipril, which will help in protecting your kidney? Because they said that, no, your kidney is very likely to be safe as long as you're taking a drug. I have listened it or I have read it in newspaper. So what is your comments on it? Dr. Tara, you start.
Okay. Thank you, Dr. Kumar, and thank you for making our job a little bit easier. Like we are looking for, RCTs and different studies all day. And now we are talking in the patient's basis. So now I think that I'm talking to my patient in my OPD. Very nice question. Definitely, yes. If the patient is less than 40 or around 40, and if he doesn't have hypertension, if he doesn't have hypertension, and if he doesn't have micro or macroalbuminuria, then adding ARBs or AC inhibitors, I don't think, I'll not advise him to take any medicine. But if he is diabetic, or if he has some sorts of microalbuminuria or macroalbuminuria, then definitely I'll advise him to have either SC inhibitors or ARBs according to the choice, or sometimes according to the availability in our settings. So definitely I will advise him that if at the moment, I think he will not need any additional SC inhibitors or ARBs. Definitely.
Thank you, Dr. Tara. It is actually, say, a decade back when the trial called HOPE, or 2 decades back it was came. Everybody started giving 2.5 milligrams of ramipril with the hope of preventing kidney disease. It never prevents kidney disease. It only prevents the progression from a minor stage to a major stage. That is a small proteinuria to a bigger proteinuria, it prevents, but prevention of a kidney disease, it never does. So thanks for highlighting. Any comments from Dr. Niba or Dr. Amna?
So I think he has presented it very beautifully. That's what it is about.
Okay. Now,
yes, just one point. Whenever there is albuminuria or proteinuria, and you start it, then you have to check the kidney functions and electrolytes after starting them, because that is important, and then we have to check it in the follow-up. So the patient should know that when you start these medication, although they help, but you have to check the electrolytes and the kidney functions in the follow-up and then maintain it.
Yeah, exactly, Dr. Reyes. I would like to add one more thing, that a patient may be confused if after 2 weeks their creatinine level might have gone slightly up. So I request my patient not to be worried that much. That is the things what we wanted to work on your kidney. So after sometimes that will come back to normal, and this is the adaptive phenomenon of your kidney. So no need to worry, and you have to keep on continuing the medicine. Sometimes patients may be afraid, and they stop. They might have stopped themselves. So I'd like my patients to be sure and be confident not to stop that medicine.
Correct, absolutely correct. That education, whenever you are starting about the likely side effect or likely worsening, is what is the key. Thanks, Dr. Amna, for pointing it out. It is absolutely, the patient is well prepared for the slight rise in the creatinine, or he is not worried about it. Thanks for putting. We will go with the same patient journey and discuss the cardiovascular issues. Now that patient has gone to a XYZ physician and he has prescribed 80 milligrams of atorvastatin. He says this is the best drug. You will not get any heart problem. 40-year-old gentleman, well controlled as far as diabetic status is concerned, non-obese, non-smoker. So what would you think would be the ideal way to give a statins in him?
So, okay, that's a very important question, because it's different from the aspirin, where we hold it or we are reluctant to give it in anyone below 50 and anyone above 70. But in case of statins, the data, it has shown that it reduces the cardiovascular events markedly. So here we like to give from the age 40 to 75 without even who are diabetics and without any cardiovascular risk factors. Even then we give statin, but it has to be given in a moderate dose, like the LDL reduction aimed at like 30 to 49%. So the dose would be like 20 to 40 milligram, not 80 milligram. 80 milligram is a high intensity statin, and that has to be reserved for even the 40 years old patient, but with additional risk factors. And the risk factors would be like hypertension, kidney disease, smoking, or a family history of early cardiac disease. Then you give high intensity statin to those patients with aim of LDL reduction of more than 50%. But again, giving a patient a high dose statin with no risk factors, there are side effects of statin as well. So every drug has side effects. So you don't want to put additional burden, pill burden, cost burden on a patient who doesn't require such high dose.
Thank you, Dr. Amna.
If you want me to extend a bit, we should be aware even above 75 and below 40, it has to be not like don't give it to everyone. You have to risk stratify, and you give it to the high risk patient, and again who don't have established heart disease or cardiovascular disease. You give it in the moderate intensity. So the high intensity statin without a cardiovascular disease should be reserved for 40 to 75 years of age who have additional risk factors, major risk factors. So that you don't expose everyone to high dose and their side effects and the complications.
Thank you, Dr. Amna. Yeah, it is. A statin doesn't fall in the same group. Statin, I mean, is a drug which reduces the cholesterol. The ecosprints and aspirins are the ones which prevent heart attack. They both are in the, I mean, ultimate aim is the same, but different actions. So a drug which reduces your bad cholesterols are definitely required for diabetics. The dose can keep varying depending on the profile of the patient, as Madam has said, depending on the risk factors, depending on whether you had a vascular event in the past or not. So it is important to put the patient in an appropriate category and then possibly give a drug accordingly to the patient, which will give him the maximum benefit. And elderly patients, definitely the benefit versus risk is more towards the risk. So you may use a lower dosages than what in a otherwise. The maximum benefit you would see in that 40 to 75 age group. Any other comments from the other two panelists, Dr. Tara or Dr. Oniba?
Exactly, Dr. Amna has said absolutely right, and we also do same practice in our routine.
Explained very nicely, yes.
Yes.
Okay. Now, the same patient, Dr. Amna has prescribed 40 milligrams or 20 milligrams, and he has put it in Google and said that it is going to cause diabetes or it is worsening my diabetes. And he reaches Dr. Uniba's clinic and said, Madam, I am not happy because my diabetes is getting worsened because of the drug which he has prescribed. So, Dr. Uniba, your take on how best to tackle this and what are the apprehensions in the patient's mind? How do we go about?
The first thing is that diabetes with statin, it's a fact. This is a fact and it does happen, but the thing that we need to know is, am I audible, please?
Yeah, you're audible.
Yes,
Am I audible? Okay, okay. So the thing is that we need to know two things. The patient needs to know two things. Firstly, when we talk about the hyperglycemia or diabetes with statin initially, firstly, it is, the larger, the bigger the dose, the more risk it is. The other thing is that you have to have all the recipe of diabetes or hyperglycemia within you as well. That means the risk factors. The obesity, the hypertension, hyperlipidemia, all of these, or the family history, all of these, this recipe has to be there for statins, to go with the diabetes stuff. If then, if patient like Dr. Amna has said that, the statins are prescribed for a reason. And if there is a side effect as well, that is obviously that is mentioned and that is well established. So you have to weigh whether the risk or the benefit. And for the patient's sake, I'll take the real example. That is in a study with 255 patients, one patient would get diabetes and 5.4, there is 5.4 times reduction of the cardiovascular, the risk factors or events. So 1 against 5.4, you obviously opt for the 5.4 reduction thing. So you should, and if you really want to, if you really want to see that this does not happen, what you can do is you should not stop the statin. However, all the other risk factors that you have, like if your weight is towards, you're overweight or you are on the obese side of the BMI scale, you should lose the weight, you should control your hypertension, you should stop smoking, you should, control the other risk factors that are adding on to it. That will be okay with, with you taking statins as well. It will benefit you more. The benefit will the patient more, as and as compared to if you stop taking statin and fear of having uncontrolled diabetes or diabetes per se.
Thank you, Dr. Niba. Actually, absolutely correct that you need to just emphasize that the benefit of taking the statin far more than a mild increase in the hyperglycemia. So that is what we need to emphasize. This is mostly relevant in secondary prevention setting where we use more of a potent statins. Suppose somebody wants to use a maybe a primary prevention, just a statin. Dr. Tara or anybody can comment. What would be the best statin to give if somebody is just, you're trying to just control the lipid, he has never had a vascular event in the past?
Oh, I think available is available. I think rosuvastatin would be the better option, for example, in our setting. But you know, like if there has been, I think, studies with compared with atorvastatin versus rosuvastatin. So rosuvastatin was slightly better than atorvastatin. So I think the low dose or a low intensity rosuvastatin would be better to start with in such patients. One thing I want to highlight is the actual mechanism why the statins is causing diabetes. It's still not clear, but there has been very much, you know, like talks about it. But one thing what I want to tell my patients is there has been one nutritional study. What they found that if the patient is on statin, he will be somehow relaxed, and you know, like, and keeps not focusing, and he will start not to focus on his diet. So it has been a very interesting study, and they found that those who were you know, like, it's a nutritional fact that patients will start gaining weight. So you can tell the patient that even though you are taking the statins, you're you know, like, you have to control your fat diet. So you can tell one thing, it will at least somehow might prevent your you know, like, occurrence of diabetes. So this is just a, you know, like, assumption, or, you know, one or two study. It cannot be, you know, like, validated to all, but still, what you can tell the patients.
Thank you. It is actually the emphasis on the diet and lifestyle should be done at each and every visit to the clinic. That is what is the important one. There is no harm in emphasizing about the diet, re-emphasizing, re-emphasizing, because most of the times patients forget, or because it's a long-term illness, so they tend to slacken over a period of time. So thanks for bringing out that point, that it is emphasizing about the lifestyle modification at every visit pays rich dividends in a long-term practice. Thank you. Dr. Tara, we go with you only. This patient whom we are discussing, he has no complaints. He's 45-year-old gentleman with good amount of A1C, good control with 2 drugs. Now, his friend unfortunately had a heart attack and died. And he says, I don't want to die of heart attack, and I'm visiting doctor regularly. So doctor, tell me, what can I do? I don't want to die due to a heart attack. So how do you screen, or what should be the measures to educate him that what are the things to follow? I mean, other than lifestyle and other things, what should you screen and when should you screen?
Thank you, Dr. Kumar. I think this is the most important part of the discussion, I think, from my opinion. So diabetes itself, we know that it's a major risk factor for cardiovascular disease. So whenever if a patient has diabetes, he's already in the high risk of having heart attack, having heart failure, or having sudden cardiac death. So holistic approach as a physician or endocrinologist must be there. We should not focus always on controlling his blood sugar. All right, so we have to focus on his cardiac status as well. So whenever we see the patients, we definitely do physical examination. We take history. We do some sorts of tests like electrocardiogram. We do auscultate the patient. We palpate his pulse. This is the routine things that we should never forget. If you talk about the screening of overall population for cardiovascular disease, you know, like, we have to consider 2 or 3 things. First of all, we have to consider the prevalence of certain disease whenever you screen in a society. Okay, if you talk about India or Nepal, definitely we have high prevalence of cardiovascular disease and diabetes. So that's why, in case of high prevalence, there is a chance that we should get the false negative results. We should always take in mind while we screen the patient. Secondly, the test what we're gonna do to the patient should be cost effective. We cannot let the patient to have a very high, expensive analysis like SPECT scan or PET scan. If somebody wants to do, he wants to know whether he has a cardiac problem or not. And another thing is the test should be accurate. It may give false result to the physician, and it will ultimately lead to the unnecessary treatment or unnecessary burden to the patient. And one thing that what we should note that result from the test and what the physician do after that should improve the outcome. It should improve the cardiovascular status of the patient, should improve the primary outcomes like myocardial infarction, heart failure, unstable angina, or at least admission or even the death. So we should already think of that. So in case, if we talk about our patients, he is quite, young, 45 years. He has diabetes. And I should say that it depends on the setting where we are treating the patient. Okay, if we are treating the patients in the, where we don't have so much supply to the sophisticated investigation, I will go for simple tests like stress electrogram or echocardiography of the patient. I'll take ECG, and then I'll do some sorts of investigation, like I'll check for the lipid profile. I'll check his apoprotein A level. I'll check his microalbuminuria. So I'll go more on clinically. There has been studies which said that, if you do SPECT scan or coronary calcium scoring systems, and yeah, we can get the patient, we can catch the patient early. So what they found that, yes, we can catch the patient early, and yes, there has been studies which have shown to decrease the myocardial infarction or heart failure, but overall death or all cause of mortality has not been improved so far. So as European society or American society, they stress that they have clearly discouraged for mass screening for all patients. But I will suggest that we have to individualize the treatment, and depending on the patient's condition, age, gender, even the family history. I will take it very importantly. If the patient has a family history of high risk of cardiovascular disease, if he has the first degree relatives, male less than 65 years or female less than 55 years who has cardiovascular events, or if the patient is more than 48 years, if the patient is smoking, if the patient has microalbuminuria, then I will definitely let the patient to go for screening. Otherwise, basic tests which I will do in my clinic will be enough, and I'll tell the patient that it will be not cost effective, and treating the hypertension, treating the lipid properly, looking for the microalbuminuria, looking for any cause of neuropathy, and controlling the blood sugar and maintaining the HbA1c. I think that would be enough at this setting in our scenario.
Thank you, Dr. Taga, for highlighting the basic things what are required, and they will give you the maximum dividends. Clinical examination, put your hand possibly in all four limbs and look at ankle brachial index, and possibly a simple ECG will give you the maximum relevant information. ECG is available every nook and corner of the world. You don't require any of the high-end tests. Even if you are practicing at Mayo Clinic, you only require this as far as screening asymptomatic patients are concerned. If somebody has got symptoms, fair enough, you can do as per the availability, as per other things. If there are changes, you can do as per others. Any comments from Dr. Uniba, Dr. Amna?
From me, I think I would like to give a take-home message is if there are no symptoms.
Okay. In this setting.
In this setting, if there are no symptoms, then intensive cardiac investigations are not required.
Absolutely.
They are not recommended.
Simple annual ECG, good enough.
Agree to it. There is an ideal situation and there is a realistic situation. So we being, developing countries, we should stick to the realistic situation. So I think he has made his point very clear.
Yeah. Okay. Now we move to another issue as far as the same cardiovascular risk factors, diabetes being one, a second being hypertension. These are the two biggest contributors for the cardiovascular mortality, even in diabetic or non-diabetic. Now, the same gentleman has in your clinic recorded a blood pressure of 140/90. Okay. Dr. Amna, he is in front of you. He is 45-year-old, well-controlled diabetic, 140/90 his BP. You, in your wisdom, what would you do?
So this is a very important question because diabetes and hypertension, they coexist frequently. And we see that most of the diabetic patients have the blood pressure, which are maybe 140 or 90 above. But when you check the blood pressure, like in this case, then you have to reconfirm it because there are other factors. Patient could be anxious. There is a term called white coat hypertension that could be present. So I would tell him to go home and check your blood pressure at home, sitting comfortably, and check it and make a chart. Or if available in certain setting, we don't have such setting, but if 24-hour ambulatory blood pressure monitoring is available, then that's a perfect thing. And after rechecking and reconfirming it on several occasions, if it's still above 140/90, then it is recommended to treat it, because hypertension, it's a major risk factor for the cardiovascular disease. And recommendations are generally, if the blood pressure is more than 140/90 on several occasions, then it has to be treated. And if now if you extend it to how much it should be or how low it should be, then it would be like we have two recommendations from two different societies. So there is one, American Heart Association and American College of Cardiology, and they say generally for all patients, all groups, blood pressure should be targeted to below 130/80. And if we say, or if we follow American Diabetic Association, then they have individualized the targets to different groups according to their risk factors and potential adverse effects of the intensive treatment, or if the patient prefers to have a slightly higher blood pressure. So in the patient who have high risk, then it should be, blood pressure should be high risk for cardiovascular disease, basically. Then the blood pressure target would be 130/80. But like in this patient, in this young patient who has no other risk factor, he's well controlled. And if we calculate his 10-year risk and it turns out to be less than 15% maybe, then a blood pressure target of less than 140/90 is good enough. And again, before starting any treatment, again, we have to emphasize the diet, that is the low sodium diet and what we call a DASH diet. So which include low sodium and more of vegetables, and taking 3 to 4 servings of fruits and low fat dairy, and quit smoking. So lifestyle modifications come first, and usually people do respond to diabetics, early diabetics, young, they do respond to this lifestyle modification, and they do control it before even they don't even need the medication. But we should know when to start and what should be the targets.
Thank you, Dr. Amna. Very rightly said. One, get your blood pressure checked during every visit in the clinic. If possible, even at home monitoring is advised. And look at 140/90 as the cutoff for majority of people. In a given patient, if there is risk factor or somebody can go, you can use it at 130/80 also, will give you a optimum control. What best drug, the doctor, whoever is treating you, will decide. But by and large, keep these values which you should remember, because if somebody else is not paying attention to it, you should be asking your doctor, please, my blood pressure is high, what should I do about it? So that is most important. Now we have only 5 more minutes to go. We will leave the cardiovascular issues and we will come back to the bread and butter, the glucose issues. Patient is on metformin and vildagliptin when he started with, okay? So we will go to Dr. Uniba first about the issues concerning, cardiovascular issues, because last decade we have a lot of issues about cardiovascular data in anti-diabetic agents. Quick comments about metformin and gliptins in the cardiovascular issues.
So, Dr. talking about metformin, I would tell the patient that metformin is in the market for like past many years, like 1960s somewhere. So it's a time-tested old drug, and if it's still the the drug of the first line of the drug of choice, then there has to be a reason. Now metformin has not shown any adverse effect when cardiovascular system is concerned. Rather, if you look at UKPDS, it has shown that there is almost, if I'm right, 39% reduction in cardiovascular mortality. Kafi tik-tak, so it's a bigger number. An important thing is that it was sustained for 10 years. Post the study, it was sustained, that effect was sustained for that. So as far as cardiovascular thing is concerned, apart from having a good glycemic control and the effect on the insulin resistance and stuff, this cardiovascular beneficial effect on cardiovascular system is proven as far as UKPDS study is concerned. The other thing is you I guess talked about DPP4 inhibitors. Yeah. So DPP4 inhibitors are relatively newer drugs, and they have a little larger data and a little more studies, if I would say, on basis of cardiovascular being beneficial for cardiovascular or being not for that. This includes the atherosclerotic stuff as well as the heart failure. More studies on the atherosclerotic and the DPP4 inhibitor, they also have proven to be beneficial and not on the derogatory side, if I would say.
Okay. Dr. Tara, your quick take on the glitazones led all this drama as far as cardiovascular issues. Some of us still use, we have only a bioglitazone mostly available. Your comments about glitazones and maybe sulfonylureas, which are one of the oldest ones.
Yeah, thank you so much. Glitazones definitely the most controversial agents so far. But being trained in India, I'm a little bit more favoring glitazones. I don't know why. Maybe. But if you see, talking about the rosiglitazones, and it's definitely from 2007, we know that the FDA has put it in the black box, saying that it has some sort of cardiac issue. But if you keep on analyzing the data, there has been some issues that it is actually not that bad as used to be. And talking about the pioglitazones, yes, I do use in my clinic, but very selectively, definitely. In case of cardiac safety, yes, it has been very good in controlling your blood sugar as well. If you are young enough, it has high, increase your insulin sensitivity. Even insulin, the glucose uptake by skeletal muscles as well. There has been a side effect. Basic side effects is fluid retention. So because of the fluid retention, yes, there has been issues with the heart failure. But still, having said that, there has been positive issue with the pioglitazone as well. They say that it causes edema, distribution of the fat. If you talk about the distribution of fat, actually it causes the visceral fat to shift to the subcutaneous fat. And this is actually beneficial. It's actually cardioprotective. If you see the literature, moving visceral fat is bad, but if it is converted to the subcutaneous fat, it is cardioprotective. So this is good. Actually, it's good. But edema, because of the sodium retention properties of the pioglitazone, patients develop fluid retention and they cause heart failure. So old patients is not good because of the issue with the decreased bone mineral density. But if the patient is very young, I still do prefer pioglitazone. Talking about sulfonylureas, as we know, this is I think the second most drugs prescribed still worldwide, and in Nepal, I think every other patient is taking sulfonylurea. There has been issues with the sulfonylurea that it will worsen the cardiac, preconditioning, and then hypoglycemia. Yes, definitely, it is the most, I think, aside from insulin, it is the most hypoglycemic agent. So we have to be very careful about the hypoglycemia. But what I would like to tell about, it is not the class effect. It is the agent-specific effect. Please be sure that the first generation sulfonylureas, yes, they do have this kind of effect. But if you talk about the newer generation of sulfonylureas like limepiride or gliclazide, they are better. And even in the studies, they said that they are not that bad. Talking about the new trial of Carolina trial, which we know that it's not that bad, that people used to say that it will cause heart failure or heart attack. It will increase the cardiovascular risk. It is not that issue, but I will say that sulfonylureas are cardiovascular neutral. I will say like that. They are cardiovascular neutral. And talking about the cost issue and availability, this is still, like we have to use these agents. Yes, there have been lots of other agents, very expensive, not available in our setting as well. So sulfonylurea, definitely wonder drugs still, though it will not work later on, like after a few years, it will not be not that effective. In older patients, you have to be very careful. You can use other sulfonylureas or ripaglinide just to lower the side effect of hypoglycemia. It's more friendly. Ripaglinide is more friendly in elderly patients. But yes, we use sulfonylureas, and I think they will not increase the chance of heart attack or heart failure. But I will say that if you use it properly, they are neutral. They will help us to decrease the HbA1c around 1.1 to 1.5%. And definitely this is our target.
Thank you, Dr. Tara. We will go to Dr. Amna for the easiest part of the question. Your comments about the GLP-1 and the SGLT2 inhibitors about cardiovascular issues.
Okay, they are the most favorite and most talked about these days. And of course, everyone, when for every drug we are talking about, they don't increase the cardiovascular risk. We have something that decreases the cardiovascular risk, and that's for the GLP-1 receptor analogues. They are available in the market. They are although injectable, but they are non-insulin therapies. So for the liraglutide, semaglutide, once weekly injectable, and dulaglutide, they have shown a significant reduction in major adverse cardiovascular events in diabetics who have cardiovascular disease or they have high cardiovascular risk factors. So FDA has approved the semaglutide and liraglutide for the use in diabetic who have atherosclerotic cardiovascular disease. Although their effect on heart failure, they don't increase the risk of heart failure hospitalization. So in contrary, if we talk about SGLT2 inhibitors, they have a major effect, major positive effect on heart failure hospitalization. They decrease heart failure hospitalization significantly. And so the recent data, or after the recent trial, they are also recommended in heart failure patient with reduced ejection fraction, meaning thereby if their pumping capacity has reduced to certain limit, then even if they are non-diabetics, the recommendation is that they should be given SGLT2 inhibitors. And regarding the cardiovascular safety, they have a good safety profile. They don't increase the adverse cardiovascular side effects, and they are going up on the list after metformin in the patients who have cardiovascular disease and who have heart failure, or even in the patients who have kidney disease due to diabetes, albuminuria, and chronic kidney disease. But you have to be very careful in that condition. In that situation, you have to assess the volume status and creatinine and the total amount of the estimated kidney function at that time, because under certain limits we can't give SGLT2 inhibitors. So overall, good safety profile. Cost is a major issue with GLP-1 receptor analogs. But SGLT2s are pretty much available all over, and they are given and being prescribed, and we are getting very positive results with that.
Thank you, Dr. Amna. I think we are at the end of the session. We have overshot by 9, but we started late, so we have within our given stipulated 45 minutes. Before I wind up, just a 20-second closing remark from each panelist. I start with Dr. Uniba.
I'll just say one word, that is individualize. My message is individualize. Not every treatment works for everyone. Okay. And don't go if your friend is benefited for one drug, it might not be good for you.
Thank you. Dr. Tara.
Yeah, thank you, Dr. Kumar, for being very, such a good moderator. You made our job very easy. And I really agree with Dr. Univa, right? You have to individualize the treatment very much. There is no one key for every lock. So we have to be, individualize the treatment, and it's all patient-centric. And thank you so much.
Thank you. Dr. Amna?
So from me, it would be like cardiovascular disease is a major cause of mortality in diabetics. So you have to check for it, check blood pressure at every visit, check lipid profile at diagnosis, and then gradually follow it, check for symptoms, and then treat all the risk factors to prevent cardiovascular disease, mortality and morbidity both.
Thank you. With this, we come to the end of
before
the
we
panel.
leave, I'll just have to say thanks to Anshita.
Correct.
She has
I was
been
about
great
to
with us.
She
was great. She was in
person
contact
who
with
made
us.
all this possible is the one who is Dr. Anshita. She is the one who has put in the maximum effort for this panel.
Exactly.
On behalf of the entire panel, I give 3 cheers to Dr. Anshita.
Well, exactly.
So hopefully, very soon, with the end of this pandemic, we'll be able to see in real life, not in virtually. So we'll have one group photo together. I'm really looking forward for that.
Absolutely, absolutely.
It has been a great experience.
And Dr. Hari, you have been a wonderful host, and you have made
no
our
doubt,
job.
no doubt.
And
a different approach, different way of doing it.
Indian Endocrine Society for this Diabetic Awareness Week. It's the need of the hour. We need to we need to make the masses aware of this disease, and because it's spreading, it's like a pandemic. So we need to control it to avoid all the complications and making people live a healthy life.
Thank you everybody for taking your time out and joining us. Have a great weekend ahead, and hope the education continues. We shall keep getting involved in more and more activities. Thank you all.
So much.
Thank you, Dr. Anshita.
Thank you, everybody.
Thank you everyone. Thank you, everyone. Okay.